Thank you for sitting tight while we worked out our technical issues today. We're going to go ahead and begin our webinar. Welcome to the webinar today on HRSA's Geriatric Workforce Enhancement Program, facilitated by the National Alzheimer's and Dementia Resource Center, which consists of our team at RTI International. I'm Siri Schumann with the Resource Center team, and I will be moderating our webinar this afternoon. The purpose of these webinars is to provide helpful, current, and applicable information for ADSSP and ADI-SSS grant projects and others in the Aging Network. Please note the webinar today is being recorded, and the PowerPoint presentations will be sent to all of you soon after the webinar. We will allow time for questions through the webinar's chat feature at the conclusion of the presentations. If you have a question during or after the presentation, please enter them into the chat feature of the webinar. Today we'll hear from Drs. Joan Morley and Erin Emery-Tiburcio with an introduction from Joan Weiss. I'm going to turn it over to Joan Weiss for the presentation. Joan?
Thank you. Good afternoon, everyone, and thank you to the Administration for Community Living for this opportunity to present the work of two of the Health Resources and Services Administration's Geriatric Workforce Enhancement Program awardees. Before we hear from our two main speakers, I would like to provide a brief overview of the HRSA Geriatric Workforce Enhancement Program, which we call GWEP. In 2015, HRSA revisioned its 4 geriatrics education and training programs into one program, the GWEP. The purpose of this program is to develop a healthcare workforce that maximizes patient and family engagement to improve health outcomes by integrating geriatrics with primary care. And trainees include patients, families, caregivers, the direct service workforce, as well as the health professions workforce. This program focuses on providing the primary care workforce with the knowledge and skills to care for older adults by collaborating with community partners to address gaps in healthcare for older adults through individual, system, community, and population level changes. All awardees are required to provide interprofessional education and training and partner with at least one primary care organization outside of their own organization and one community-based organization. All awardees had the option of providing Alzheimer's disease and related dementia training, and I am pleased to report that all have incorporated this training into their grant activities. We awarded 44 grants in the amount of $35.7 million, of which $5.2 million is for dementia education and training. And you can see here that awardees include schools of the health professions, as well as healthcare facilities and the certified nursing system program. We had a goal to fund at least one GWEP in each region, and this slide shows that all 10 regions have a GWEP ranging from 2 awardees in regions 6, 7, and 10 to 8 awardees in region 9. And the 9 on the slide here is a typo. It should be 8. All awardees address geriatrics training needs of medically underserved populations, including rural populations, the homeless, and Hispanic and Native populations, and they address a variety of topics that include but are not limited to dementia, public health, telehealth, and elder justice. This slide shows the GWEP community-based partners, and as you can see, there are 25 partnerships with area agencies on aging. And this next slide shows some of the primary care partnerships. In summary, the GWEP program is working with community-based organizations to transform primary care clinical sites by integrating geriatrics into their practices. And with that, I'd like to turn it over to Dr. Joan Morley.
Thank you, Joan, and it's great to be with all of you and be able to share with you today. I'm going to talk a little bit on our best practices, a focus on dementia, and try and point out some of the things that can be easily done in the community. So just as a starter, in this slide you can see the old woman, and it's pointing out that memory is a passion no less powerful or pervasive than love. We have to remember that there are really only three things that matter for any animal all the way up to human beings, and the first is obviously we have to be able to feed. The second part is we have to be able to reproduce, and then when we've reproduced as an animal, you have to remember how good it is, so you will feed more so you can continue to reproduce. And while that may sound simplistic, it really is what life is about, and so this is where memory becomes so important when we look forward to what's going on. So we've all heard about Alzheimer's disease, and the probably most interesting thing about Alzheimer's disease is it should never have been called Alzheimer's disease. Alois Alzheimer reported on a 53-year-old woman, Augusta Dieter, who had a premature form of dementia. He showed that there were amyloid plaques. Amyloid plaques had been shown in the previous century to exist, and clearly this is not what we think of as the common Alzheimer's today. It turned out that Oskar Fischer, at virtually the same time, working in Czechoslovakia, not Germany, actually came up with a series of older people and found the plaques and tangles. But Alzheimer was lucky enough to work for Kraepelin, who created the first taxonomy, and he was more interested in his school becoming important than having any reality in the name. You can see here Simon Carter Fuller, who actually had the first major report on Alzheimer's. He did this about a year before either Alzheimer or Fisher. He was an African-American working in Boston, and somehow he just never got any credit at all. So I guess sometimes the world is difficult, but we still call this Alzheimer's disease, or dementia as a whole, as Alzheimer's disease. So how common is dementia? Dementia occurs about in 8% of people over 65 years. In addition to that, about another 8% are in the twilight zone. They have mild cognitive impairment. By the time we get to 85, about 1 in 2 of us is going to have some degree of cognitive impairment. So one of the most important things is families and physicians do a terrible job at recognizing dementia. Most family members, when they bring a family member to me who has got dementia, the person has had clear signs for between 2 to 5 years. And they think, well, it's just mom, she's just different, she's old. And that's what tends to happen. When we look at physicians, we and others have shown that in general internists, somewhere around 90% of people with dementia don't have the diagnosis made. When you look at the family practitioner, they do somewhat better, but they still miss about 25% of the diagnoses. So one of the questions that arises is whether or not there should be universal screening. This is involving screening of all individuals in a certain category. For example, we would say everybody over the age of 65 or 70 or 75. Versus case finding, which involves screening a smaller group of people based on the presence of risk factors, for example, subjective memory problems, mainly in a physician's office. Screening interventions are not designated to be diagnostic and often have significant rates of both false positives and false negatives. So when we start to look at this, the IAGG, the International Association of Geriatrics and Gerontology, felt that in their position statement, healthcare professionals need to know how well patients can follow instructions. There are treatable causes of cognitive function. Lifestyle intervention can slow the rate of cognitive dysfunction, and early diagnosis allows the development of advanced directives. It's important to point out that many other groups do not agree with all of this. In the case-finding part of IAGG, a number of the neurologists in the group said, we just don't have enough professionals to look after these people, so we shouldn't screen for that reason. I think that is quite honestly, a terrible reason, and I couldn't believe they were saying it, but nevertheless, that's what they were saying. Lots of people do not believe in treatable causes for cognitive dysfunction, and I'm going to talk about that and point those out to you. There's argument about the lifestyle interventions, but they all are safe, and in addition to this, they seem to have a fair amount of data to support them, and early diagnosis certainly is important in a health professional office, one, because the health professional needs to know if I am talking to a diabetic and I'm trying to tell them to prick their finger to alter their insulin levels, can they think? If you can't think, you're not going to follow the instructions very well of the healthcare professional, and this is the time when you have early cognitive impairment to make sure that you develop your advanced directives. So this is just one example. This is looking in our endocrine diabetic clinic here at St. Louis University, and we're looking here at mild cognitive impairment and dementia, and you can see even at the age of 50 to 60, about 20% of diabetics have mild cognitive impairment, and it tends to go up as they get older. Absolutely key in diabetes, but also in heart failure and many other conditions, that the physician knows this and is aware that they need to write down instructions, and also most probably need to talk to a caregiver about what needs to be done if the patient is going to get good care. So the major need for case finding is that healthcare physicians need to recognize the mental status of their patients to be able to tailor their general instructions to the patient. This is exactly the same as knowing the health literacy of your patient, and very, very important in the care of every patient. This shows you here some of the patterns that you see. So if we look at pattern A, this is basically the person with Alzheimer's, and they're starting off just doing about normal, and then slowly they go down through MCI and they finish up getting dementia. And this is an ongoing process. Mostly they have problems remembering words early on, and that suggests that there may be Alzheimer's disease. The second group here, we're looking at somebody who has mild cognitive impairment, but they tend to stay there. They don't go down, and if anything, they might sometimes get a little bit better over time. In our studies, we found that about half of the people with mild cognitive impairment, if they get appropriately treated and treatable causes are treated, about half of them are going to actually revert to normal. The third group here is somebody with wax in their ears. Wax in the ears, as you can see here, you take it out and you take somebody who's cognitively impaired and you move them into the normal. You keep on taking the wax out, they do well. The improvement with taking wax out of the ears is identical to getting the drug Aricept or donepezil. So before you rush to give a drug to somebody with Alzheimer's, maybe looking in the ears and removing the wax might make more sense. And then finally, we've got a patient here who basically was a lawyer. He wasn't functioning very well. He came to see us, and he had a slum score of 16 out of 30 and was truly demented. We asked his wife if at night she had to kick him to wake him up because she thought he was dead and had stopped breathing. She said yes. We sent him for a sleep test, and after the sleep test, we got him into CPAP, and you can see 6 months later, now with his CPAP, he's perfectly normal and functioning again. So these are different patterns that we see with dementia. There are a number of reversible causes of early dementia, drugs such as digoxin, theophylline, any anticholinergic drug, emotional depression, metabolic, hypothyroidism, B12. We've talked about the eyes and ears, normal pressure hydrocephalus. These are the wild, wacky, and wet people, wobbly and wet. Tumor and other space-occupying lesions, infections, syphilis and chronic infections, atrial fibrillation, vitamin B12 deficiency, and alcoholism, and then finally sleep apnea. People struggle sometimes with mnemonics, so another way to look at this is to look at the presidents of the United States. This is Coolidge. I'm sure you all recognized him. His child died while he was in the presidency, and he retired to his bed, and his wife looked after the country thereafter. The second person here, I think you all recognize, is JFK. He's very famous for basically telling Khrushchev we wouldn't have nuclear missiles in Cuba, and Khrushchev backed down. But if you think about it, if Khrushchev hadn't backed down, we would have destroyed the whole eastern coast of the United States as we had a nuclear war. And so you have to think, why did he do this? And we know that he had steroid deficiency, so I assume he forgot to take his steroid replacement, and he had a mild cognitive impairment, because I can't think why anybody else would have wanted to start a nuclear war. We all remember Mr. Reagan. Depending whether you're Democrat or Republican, Mr. Reagan either fell off his horse on the first day of the presidency, or he did it at the day after he finished. And we know that he had bilateral subdurals, and he went on to get Alzheimer's disease, bilateral subdural space-occupying lesion. Here we see FDR. FDR, when he was negotiating with Stalin to give away half of Europe to Russia, actually had a hemoglobin of 4. This was due to his bleeding hemorrhoids, and he wasn't thinking that well. I think we all remember Mr. Bush. Mr. Bush told me when he was running for presidency that fundamentally he was going to spend unending money on the Army, and at the same time he was going to cut my taxes and balance the budget. Obviously this doesn't make much sense. There was a history perhaps that he used to drink quite a little bit when he was younger, and in medicine we would have called that confabulation. Next president we see here is Mr. Clinton, and I'll point out to you the bottom one from the 3, the third from the bottom, is one that he might develop, but most probably hasn't developed at this moment in time. And then Howard Taft had sleep apnea as a cause for his dementia. Obviously this is being done a little bit tongue-in-cheek, but it's to remind you that there are things that are very reversible that happen to people to cause problems with their thought process. This is just pointing out to you that if you're going to screen for people, you have to explain the screening up front and make sure the person understands and is happy to have it done. You have to have an environment that is maximum to do this. You use a standard way of administering. You have to share the results simply and clearly with the person you screen. You've got to make sure they understand it. You've got to look and see if they're distressed, offer recommendations, and always give verbal and written feedback. You should, where possible, have a follow-up if the person has cognitive dysfunction to see whether or not they're doing okay and whether they got help. So how do you screen? The quick way to screen is the Rapid Cognitive Screen, which was developed here at St. Louis University. It has 5 words in it. You then draw a clock. So after you've learned the 5 words, you draw the clock and you ask them to put in the time 12, 1, 2, 3, all the way around, and then after putting the hours in, they should put the time at 10 to 11. When they've completed that, you ask them to remember the 5 words, and then the last piece is basically a paragraph that is read to them, and it tells you that the person lived in Chicago. The question is, what state did they live in? And the state answer is obviously Illinois. If they say Chicago, you can't give them that answer. This has been shown to be very good at picking up dementia and also excellently at picking up MCI, better than the mini-cogs. So it takes about 2.5 minutes to do. In our screenings that we've been doing as part of the GWEP, fundamentally you can see here that we have somewhere around 15% at 65 to 74 have MCI, and 10% have dementia. As we get older, we see the percentage of dementia going up to 30-35%, and almost a doubling of the MCI as people get to 85. Most of these people that got screened or were seen by their physician had no idea that they had any problems, and neither did their relatives know that they had problems with thinking. We've developed a series of information sheets that are available for older persons who screen positive, not only for cognitive dysfunction, but also for frailty and sarcopenia. This is the example of the Brain Health Information Sheet. If you want to get this, you can get it off our website at aging.slu.edu, aging.slu.edu. And when we come to making the diagnosis, it's important that we don't just let people go away. We provide a different kind of cognitive stimulation therapy. This comes out of England. There are 2 manuals. It works extraordinarily well. The results have been shown to be about, again, equivalent to Aricept. If you add Aricept, they do a little bit better, but by itself it does as well as Aricept, and that is important for people to be aware of. The other thing you can do is, and this is just showing the results for the cognitive stimulation therapy in one of our nursing homes, and this was coupled with exercise, and you can see a marked improvement in the slum score in these people as well as in the brief mental status exam. In addition, we have developed Cardinals Reminiscence Leagues. This is a baseball league. We suggest that this is very good to develop for older people in your community. They love it. You can work along with the local baseball team, and it works very, very well. Finally, we have developed a caregiver well-being. Not going to go through this. It's short, but it's very important when you are dealing with people with memory problems to see how well the caregiver is doing and make available support to those people, and we are making that support through education with the GWEP. So to conclude, we basically have looked at the best practices for dementia in our setting in Missouri, and the first is to train health professionals to use a rapid screening test, and we have trained now about 12 different groups of health professionals. They can all do the rapid cognitive screen, and using the different forms to give out, including an advanced directive form, works very well. We've developed a computer-assisted management algorithm to help healthcare professionals recognize treatable causes, and if you want to get hold of a copy of this, again, you can go through the aging.slu.edu website. We've provided a lifestyle modification sheet to patients and families, whether they're being screened. All this is being done by their physician. We believe you should check for primary caregiver stress. And then finally, we should provide CST programs. You can see here the aging.slu.edu website where you can get more information. If you're interested in CST, the CST dementia site gives a lot of information. And with that, I will stop and pass on to Erin. Thank you very much.
Thanks so much, John. Appreciate it. That was great. So I'm Erin Emery-Tiburcio, and I'm talking a little bit about building dementia teams. So John's team has done some amazing work in screening, and so wanting to talk about then what comes next. So I'm going to talk a little bit about our GWEP and then talk about the teams and development from there. So our GWEP is called CatchOn, Collaborative Action Team Training for Community Health Older Adult Network, because, you know, we've all got to have these really great acronyms. And our 2 primary aims are about educating the geriatric workforce and transforming primary care systems, as Joan had highlighted. So I'm going to say a little bit more about that. The educational elements of our GWEP include interactive online training, and I'm highlighting this in this talk because we have 4 basic content areas that we're talking about, including normal aging, MCC, which is multiple chronic conditions, dementia, and working in interprofessional teams. And as John was just highlighting, all of those different kinds of medical presentations that can actually look like dementia but aren't, so we need to really understand all of them. We're providing free continuing education. There's a link there at the bottom to our website. Was really hoping to have our online modules ready for this presentation today. We had a technical glitch, so I am assured that they will be up by the end of the week. And as we're talking about teams, and I'll talk a little bit more about the makeup of the teams, but really including older adults and caregivers at the center of the team. And so with our online training, we have a version for older adults and a version for providers of each of our sets of modules. The idea being that we want to get everybody operating on the same page and really speaking the same language. And as per language, we're also going to have a Spanish edition of the older adult version coming out soon as well. And so within, we have a number of other things in our educational platform that I'm not going to be talking about today, but we will use the interactive online training to educate our primary care teams. So in CatchOn Community Health, we are working to transform older adult services within primary care. And as we do that, we have, in our experience in implementing programs in primary care, we have discovered that just going in and starting new programs really doesn't work, that we need to really learn a lot about the programs. And so we've developed a readiness assessment protocol that includes online, really brief surveys for leadership and for staff. And then we take those surveys and take a look at the data and then come back to the clinic and have focus groups with staff, with leadership, and with patients to really get a sense of what's already happening, what's the culture, how does change happen in the clinic, what are the services that are already provided, the resources available, what's important, so what are the priorities of the clinic, what are the priorities of the institution, what are the priorities of patients in the clinic. And then as we really get a clear understanding and getting everybody's buy-in in wanting to improve older adult care and primary care, then we provide some recommendations to the clinic about implementing specific evidence-based programs that utilize the existing resources of the clinic and ideally streamline services for older adults, building resources or building bridges rather into the community-based organizations, and then develop a plan collaboratively, and then provide ongoing support to implement. And so as we do that, one of the pieces that we will be working on is dementia, and really assuring that our primary care clinics are dementia capable. So wanting to talk today a little bit about building a dementia team. And a dementia team has multiple levels of intervention, as do most services for older adults. And in our concept of team, older adult and caregiver right there at the center, and need to be at the center of the team, so that they are not, we don't have care teams for older adults and families, we have care teams with older adults and families. We've got an assessment team, folks who are doing the original diagnosis, an intervention team that's based at the clinic or hospital, and a community intervention team. And I'm going to talk a little bit about each one. So in building a team, in building any kind of team, it's critical to really understand the roles of the team members. And there may be some overlap, and each team may determine that this team member is going to do this set of tasks, and this team member is going to do this set of tasks. What we recognize, though, with dementia teams is that folks who are not necessarily dementia experts may not know all of the members who could be team members and who probably should be team members. So in the assessment team, so John was just talking about some really great screening tools and how to identify individuals who may have dementia. Once we get to the point that, okay, somebody may have dementia, what goes into the assessment? Well, in terms of that team, older adult and caregiver are critical. And typically, those symptoms present in primary care. So a primary care physician or nurse practitioner may be the first person to hear about some concerns and or notice some concerns. And at that point, it may be helpful to bring in a geriatrician or neurologist who can order blood tests, can order imaging, can do a neurological exam, can do a gait analysis, a number of the different medical components. And a neuropsychologist, who I realize in a lot of areas those aren't necessarily easy to get to. But if available, having a neuropsychological evaluation can be an incredibly important element for the older adult and caregiver to identify the cognitive strengths and weaknesses of the individual, and to really help to be able to utilize the strengths to minimize the impact of the weaknesses. And similarly, when I used to do this kind of testing, there were times when I identified that the older adult actually had depression and not dementia. As John had just mentioned, that's one of the possibilities. And I remember being really excited to call up a family and say, guess what, you've got depression. This is good news. So really having that assessment can be incredibly helpful. John mentioned wax in the ears as being a considerable issue, so having an audiology exam can also be really helpful in the assessment process. Having a social worker to assess where the family is, how they're doing emotionally, what resources they have, how they understand everything that's going on. And there may be a host of others that others include here as well. But that's kind of the core folks in the assessment team. And the hospital intervention team would include older adult and caregiver, assessment team, a geropsychologist or geriatric social worker who could attend to the mental health needs of the older adult and the caregiver. Again, as John had mentioned, caregiver wellness is critical. geriatric psychiatrist who may be looking at some of the psychiatric meds to most effectively manage some of the behavioral and mental health issues that go along with dementia. And also polypharmacy, either the geriatric psychiatrist or the pharmacist, to be able to look at medication causes to determine whether medications may be causing and or exacerbating symptom presentation. SLP is speech-language pathologist, or the OT, occupational therapist. Either of those two can, or both, can help to work with the individual to develop compensatory strategies for the cognitive impairment and assure safety in the home. Eventually, that clinic or hospital intervention team may also include nursing home staff, palliative care, hospice, and some others. So in addition to the clinic and hospital intervention team, a community intervention team. And I believe this is where most of you all come in. So you all probably know a good deal more about the kinds of services that are available in the community even than I do. But in a whole host of different agencies here, again, we're starting with the older adult and caregiver, adding on the area agencies on aging and care coordination units to provide some of the in-home services, the assessment, the ongoing care management. Dementia associations, the Alzheimer's Association is the one that most people know something about, but depending on the kind of dementia that an older adult has, there are associations for frontotemporal dementia, for Lewy body dementia, and those specific targeted associations can be really helpful in helping people to work through those kinds of specific dementias. Home care providers, adult daycare staff, again, caregiver supports, folks who have resources to pay for geriatric care managers may be helpful. And we typically think about roles on this team as being specific to healthcare. But as John mentioned, when we can get an early diagnosis, having legal services and financial services in the mix is critical to be able to lay out healthcare power of attorney, durable power of attorney, advanced directives, being able to set these components up and a financial plan. Because as dementia progresses, we'll be less likely to be able to engage in those services and really assure that the services that the family is providing and the decisions that they are making are consistent with what the older adult wants. So the accountant and financial planners also for families who may be working toward a Medicaid spend down to be able to obtain Medicaid at some point, to be able to set a plan for that. So really kind of thinking outside the box in terms of some of the community individuals who would be critical to be able to communicate with the team. And as far as communication goes, very often we get communication that goes from the older adult to the caregiver, from the caregiver to the assessment team then says, okay, says here's our diagnosis, here's what's going on, to the intervention team, and then the clinic consults the community intervention team. And so that version of communication is more likely to happen in the current model. But what we really need is for that communication then to come back in and assure that the older adult and caregiver are able to communicate effectively with every level of the team. And so in order to really build an effective dementia team, we need to assure that we've got bridges across all of those different levels. So to create those bridges, we've got to start with an understanding of dementia. And there are lots of different ways to learn a lot more about dementia. So you're coming to this kind of webinar today. HRSA is going to be offering a very comprehensive version of dementia training right there at CatchOn.org. I'll put in a shameless plug for our modules. We'll have both our CatchOn modules, and we also have Carol Ferran, who is a caregiving expert in our college, and created a caregiver skill building intervention, which is an online protocol for which you can get an hour and a half of CME. Has some really great information there. But getting a really clear understanding of what dementia is and what it isn't, understanding what available services are. So even if you're a primary care provider and you're not necessarily going to be providing services that are in the community, even just being aware that they're there, so when you hear a concern, you can say, oh, hey, you know, I know there's this service available. Or if you're already in the community and being able to be aware of, say, hey, you know what, I think an occupational therapist would really be helpful for you in this case. And for everybody to be aware of older adult strengths. So often when an older adult gets a diagnosis of dementia, it's kind of like, okay, well, that's it. We're shutting the door now. They're done. And really being aware of older adult strengths, and even into moderate and sometimes severe dementia, the older adult has so much to contribute to their own lives and to the family and to the community that we really need to build on that. And so kind of starting our creating bridges with an overall understanding, then we need to develop communication protocols. And in talking with community-based organizations and primary care providers and older adults and families, one of the critical pieces is communication and understanding your audience. So when we're talking to older adults and caregivers, one of the key pieces is respect. And, we think, okay, we're all, healthcare providers of some variety. Of course we speak with respect. But the number of people who speak to older adults in what's called elder speak, which is sort of the adult version of baby talk, that sounds kind of like, come on, honey, now you can do it, just like you might speak to an infant, turns out that actually has negative impact on older adults and, in fact, changes how they react. So there was a nursing home study that actually just came out this year in the Gerontologist in which they looked at a nursing home that was engaging in quite a bit of elder speak, and they were getting quite a bit of resistance from their severely impaired dementia sufferers in their nursing home. So when they did an intervention to minimize elder speak, that cut resistive behaviors by half. So even in those later stages of dementia, when you think that nobody's home, that emotional tone is definitely heard. So I invite all of you to be aware of the tone that you take when you're speaking to older adults and assure that it sounds nothing like baby talk. It matters. Also providing information in stages. So while some very well-intentioned individuals who want to provide a roadmap for somebody who just got a diagnosis of dementia might be wanting to say, okay, here's all the things that you can expect, and here's all the services that are available, and here's everything that you ever wanted to know about dementia and everything you ever wanted to know about caregiver health. Wow, that's overwhelming. So we really need to provide as much information as we can, but in stages, in digestible pieces. That's for the older adult and caregiver. As we think about the community organization, community organizations have been telling me that, gosh, we get sometimes a referral from primary care that just says assess and treat, or maybe even just the patient's name and no specific idea about what's going on, why they're getting a referral. So community organizations are really looking for as much detail as possible. What's the medical history? What's going on? What did you see that made you want to refer to us? And what were you hoping that we would do for this patient? And what do you need back from us? So I'll talk a little bit more about how we can do that. And in talking to primary care docs, while the narrative might be lovely and hearing the whole story about what's going on at home, what they really want is the bottom line. They want just what did you find and what do you want me to do about it? So really brief, really clear bottom line. And so we've got some different ways that people are used to communicating. And so in our GWEP, in CatchOn Community Health, we are working to develop some protocols that are based on some work that we've done here at Rush in partnership with Age Options, one of our area agencies here in Chicago, to develop some very specific referral forms. So docs aren't going to spend, write out a whole paragraph of what they're seeing, but they would be willing to do a whole bunch of quick checkboxes and assure that bidirectional communication happens. So assuring that we're getting that information back through a couple of tools. One will be talking to our partners about the use of their electronic medical record, and most community-based organizations don't have access to the electronic medical record. So we'll be talking with our partners about what changes could be made to the electronic medical record, whether it's giving access, write-only access to community-based organizations so they can put their report directly into the electronic medical record, and or is there some other way that we can facilitate communication in that way. And our partners at Age Options have also had team members sitting right on the primary care teams. So when they sit down to talk about patients in weekly team meetings or monthly team meetings, I'm actually not sure what the frequency is at this point, there's a community-based organization person on the team. And that does a number of things. It kind of gets face time, so hey, don't forget about me, refer to the community-based organizations. And for the community-based organization to be able to say, hey, we actually have a service for that. Refer over here and we'll take care of that. And so lots of different ways to really integrate the community-based organizations and the primary care clinics specifically for dementia, but even more broadly than that. So as we work to create what that's going to look like for each individual clinic, we'll be learning a lot about each of the communities in which our primary care clinics operate. So again, our ideal is to be able to to be able to facilitate the communication going in every direction so that everybody on the team, including the caregiver and the older adult, are really clear about what's happening, what needs to be done, and how it can get done. So we will hope that you will visit our CatchOn.org website, and ideally by the end of the week we will have some free continuing education available for you, and hope that you take advantage of it. Thanks so much.
Great, thank you so much for your presentations. And at this time, we will move to the question and answer part of our webinar. As the layout changes for all of you, you can start to enter your questions into the chat pod there. Also, if you have any questions after the presentation, you can direct them to me, Sari Schumann, and my email address is in the lower portion of your screen where it says closing notes, or to Erin Long at the Administration for Community Living. Her information is there as well. So we'll pause for a minute while folks start to enter their questions into the question and answer pod. So we have one question that just came in, and if they're not directed specifically to one of the speakers, whoever is, feels like they have something to add can please just jump in and answer. The first question is, what advice or tools do you recommend for quick screenings of older adults with developmental disabilities or those with limited language skills?
Okay, I'll try and take that. We have used the St. Louis University mental status exam for people with developmental disabilities. It's worked very well in them, and that takes about 6.5 minutes to do. The rapid cognitive screen should work equally well, but we haven't done it in that particular population at this moment in time. It's much harder to do things in people with either visual or hearing impairment. There are a number of attempts out there, but they're usually fairly long. They take much longer to do. So I don't know, Erin, if you've got anything you could add to the visual impairment or hearing.
Unfortunately, not much. The mini-cog is the only other one that comes to mind that's also relatively education level free and very quick, and in the public domain also. But when you've got visual impairment, there are some that you can kind of modify to do that, but I'm not sure about the validation at that point.
Yeah, for the visual impairment, one of the things that you can do is take the clock out of both the mini-cog or out of the slums and just scale down because the 5 words can be learned audio by talking to the person, and they're making sure they know them because it's a memory thing. Then you would actually do these paragraph, and after the paragraph, and they'd answer the question about the state, then you would go back and ask them at that stage to remember the 5 words. It needs to be, by the way, pointed out there, the slums has been translated into nearly 35 languages now, and it's important to change where the city is depending on where you are. So in Arkansas, we use Memphis. We don't use Chicago because it turns out a large number of older people actually don't get the state right for Chicago being Illinois. You would have thought they would, but they don't. So you need somewhere nearby that everybody is used to and knows where the state is. And the same thing if you're in another country, you have to basically choose a city in a nearby country.
Great, thank you. We did have a question about replication of CatchOn. Have there been any plans for replicating CatchOn elsewhere, and how difficult might that be?
I love that idea. We've got to do it once before we can replicate it. So if anybody is interested in learning more about our process, you can take a look at CatchOn, and also you're more than welcome to email me, Erin_Emery@rush.edu, and I'd be more than happy to talk with you about what we've accomplished so far in terms of completion, so that we even have a baseline, and then what that might look like in other organizations.
Great, thank you. Another participant indicated that she's found when she screens for cognition and has a positive result, primary care physicians may not take action. As a physical therapy educator, she's wondering if you have suggestions for what else can be done for those patients.
So what we've done is we've developed those sheets, the brain health sheets, which go through things that the person can do for lifestyles such as Mediterranean diet with extra virgin olive oil, or blueberries, both of which have polyphenols in, or basically adding to that exercise, socialization. Computer games, never have people pay for the computer games. There are lots of free ones on the internet and those things. And then what I tend to do is if somebody screens positive, and what I teach the people who are screening for us is ask the question about sleep apnea, and if they get a positive answer that the person is getting woken up at night by their bed partner, to write on the top, this person may have sleep apnea, and then I tend to write, please check for hypothyroidism, B12 deficiency, and depression, and tell them to take it to the physician with those pieces on it. Most physicians will respond if you tell them what to do. I mean, I wish it was easier than that, but you almost have to guide many physicians. Training in dementia has been very poor outside of neurologists and geriatricians. So generalists don't have a lot of ideas on the whole of what to do. So by providing them the information and by writing them on the sheet, and our sheets are available if you want, you can get them off the aging.su.edu site, and you can write on the other possibilities that you think the physician should do. And it's actually worked very well for us. We've had a number of people also who come in with polypharmacy and blood pressures when they stand of 90 over nothing, and they're telling us they're fatigued and they're not thinking well, and sending them back to their physician, telling them to, here was the blood pressure, and writing on it, do you think this may be too low a blood pressure because I'm fatigued and not thinking well, and handing it to the physician tends to work. Physicians are used to getting something from their patients that was on the internet. So this is another way of carrying the internet stuff back to the physician as a training program.
And one other thing I'd just add to that is that if you don't remember all the details about what to ask for in terms of B12, sleep apnea, that kind of thing, you can also just have the patient ask for a referral to neurology. Most areas have a neurologist available not too far away if they don't have a geriatrician, since geriatricians are much harder to come by. That would be another option if you don't remember all the details. Sarah, if you're speaking, you're on mute.
So another question that came in a few different times has to do with screening tools that have been made culturally sensitive or have been made appropriate for people with limited English abilities. And you did mention the slums has been translated into a number of different languages, but is there any way to address people who may have limited English speaking capacity or have or from a different culture?
Yes, so we've done fairly well. We have it available in Chinese, Bhutanese, Nepalese, Russian, and so on and so forth. So most of the common languages, obviously, and different versions of Spanish. And the Chinese, there are 4 different versions at this moment, because depending where you live in China, you have to have a different translation for different parts of China. So a lot of this is available. We have found that we can do it with a translator, and so if you don't actually have that answer, you can get it through a translator. Most of these are now available on our website. A couple of them are not, but if you want to get a specific one, if you go through the aging.su.edu, there's a way to email us, and we'll try and get you in a specific answer. And the thing is, they are culturally changed. So if you don't speak the language, we use things that are more appropriate for the person in that particular country. My biggest shock is I come from South Africa, and they translated my American version into South African because they didn't think it was culturally sensitive to South Africans. So yes, it's very important to make translations that work, and we've been very successful doing that with different interpreters, at least in St. Louis.
Great, thank you. We have quite a few questions left. We'll try and get through as many as possible. Can you talk a little bit about for the CatchOn programs, you talked about having an interdisciplinary team where people from the Aging Network, outside of primary care, are participating in staff meetings with clinic providers. Can you talk a little bit about your process of becoming more integrated with those providers and how open the clinics were to that process?
Well, what I will say is that we have been, Rush has been partnering with our area agency, one of the area agencies here in Chicago, to do this for some time. And so we haven't actually started yet with our partner, federally qualified health centers, with CatchOn with that. So I can't speak to how open they would be to that. And it took a little bit of conversation with the primary care, I believe, to get that started, but once there, the primary care providers really appreciate having someone to be able to hand off to, and to be able to do a soft handoff makes those referrals so much easier. So so Rush is currently using a referral form that was developed and vetted by both the community-based organization and the primary care providers to make it easy, quick check boxes, and to make it useful for the community-based organization for the services that they provide. And so that we're using that Rush Age Options model as we move into our partner clinics. So I think each clinic is going to look a little different. I know, for example, Cook County Hospital, the Fantas clinic that we will be working with, they don't have team meetings about patients. And so that particular component just isn't going to happen at that clinic. But we will work with them to determine what the most effective ways will be to integrate the community-based organizations. And they're actually really excited about having people come on site to be there and to be able to refer directly to, particularly for those really high-need patients that Cook County services. So because we're still actually currently in the readiness assessment phase with our primary care providers, I'm not sure what it's going to look like in the different clinics. But as that unfolds, if you're interested in learning more about that, again, more than happy to have conversation with you about some of the options that we'll be presenting to our clinics once we learn a little bit more about their current protocols. Because one of the things that we've learned in our other program implementations is that looking at their existing protocols, at the clinic's existing protocols, and trying to integrate as seamlessly into those protocols rather than changing everything for everybody, the more changes we make, the less likely it is that it's going to actually be effectively implemented. So really trying to seamlessly integrate into existing referrals, and being really clear with primary care that the goal is to make their work easier. So the point here is not to add, okay, we're going to add in all these evidence-based programs, you're going to be doing more of this and more of this and more of this. It's completely the opposite. The idea is that if we implement evidence-based programs, it streamlines the activity and makes it simpler and less work for the physician in particular, and also for the staff, all the nurses, the medical assistants, everybody ends up being, feeling overworked. So the idea is to make it simpler for everyone. And so for community-based organizations as a sales point, that part is critical. So again, happy to talk more with you about it as we begin to implement and learn a lot of lessons about exactly what that's going to look like.
Great, thank you. Thanks so much we've run out of time, so I want to thank all of our speakers today, Dr. Emery-Tiburcio, Dr. Morley, Joan Weiss, all for joining us. This has been incredibly eye-opening, lots of good information shared. If anyone has questions, as I mentioned, you can use my email or Erin Long's email that are listed in the closing notes. Dr. Emery-Tiburcio also mentioned her email address in response to one of the questions which I entered down there in the closing notes. And for today we'll be done, but please join us again when we have another webinar next month. And thank you everyone for joining us. Good afternoon.
Thanks all.
Thank you.